Start a few minutes late here, but we have some good handouts from the research department. Yeah, we'll just jump right into it. I think we just have two things on the agenda: the approval of the committee minutes for February 25th. Gary emailed those out. Any questions, comments on the minutes? Any changes? Seeing none, the minutes are approved as drafted. For today's meeting, we have a presentation on Medicaid finances. Megan Leopold from the Legislative Research Department agreed to come kind of walk through the Medicaid finances. I think this was kind of an idea that's sprung from last week's meeting. Seemed like there were a lot of good questions, just trying to get a better understanding of how it all works. So we've got about an hour and 20 minutes or so. And if we need to, we're certainly happy to use all of that, which kind of means we'll go a little bit slow, kind of through the slides. The more questions, the better. So we'll probably stop each slide and kind of see if there's any questions. To start, Megan, maybe right after introduction, if you want to go through the handouts real quick, just so we know what they all are. All right, welcome to committee.
Thank you, Mr. Chairman. Yes, you have three handouts in front of you, as well as this PowerPoint slides. The handouts I will get to throughout the presentation, or at least point them out. But the first one, the gray memo, is the Human Services caseload estimates. This is the most recent estimates that took place in November. And each time we do estimates, we write up a memo with all of the changes included. So that is what is in there. The long page you have is a Medicaid funding chart. I have a more simplified chart in my PowerPoint, but this is the numbers that are behind that. And then lastly, the paper that says legislative additions for CanCare 2020 to 2024. This is a list of the changes that have been made to the program by the legislature in the last 4 or 5 years. And I will talk a little bit more about that as we get to that in the PowerPoint. As the chairman noted, I will go pretty slowly. This is a very high-level overview of funding for Medicaid. It's very complex, but I'm hoping I'm breaking it down in a way that is easy to digest. I'll start with the first slide. It says agency coordination at the top. The Medicaid budget is divided between two agencies. It's unique in that way. It's divided between KDHE and KDADS. KDHE oversees the medical piece of the program, so any medical services that are provided by physicians or hospitals, as well as the administrative piece of the program. So they're the state administrative head. The administrative pieces include the data systems. So they have extremely complex data systems to manage the provider payments, all of the claims that come in, the rates that are paid to the MCOs. They also have the state plan. The state plan is what outlines the state's responsibilities in the Medicaid program. They manage that, and throughout the course of every year, every month, every week, there are changes made to the state plan as the legislature makes changes to the program. They also oversee the managed care organization contracts. Kansas is a managed care program, so there are 3 managed care organizations that administer the health aspects or that administer the program. Those are Sunflower, United, and Healthy Blue. And then finally, KDHE oversees the actuarial services. These are the services that help to set the rates that are paid to the MCOs and ensure that they're meeting all the requirements. And I'll go into that a little bit more in depth here in a minute. On the KDAD side, the KDAD side oversees the Medicaid You have the behavioral health services, so community mental health centers are now, we're seeing more CCBHCs. Those are overseen by KDADs and administered through them, as well as any nursing facilities. And then finally, the Medicaid waiver programs. We hear a lot about these in the legislature, the IDD waiver, the brain injury waiver, the autism waiver. There are 7 different waiver programs, and those are all under the auspice of KDADs and included in the KDADs budget.
Representative Owsley?
Thank you, Mr. Chair. Thank you, Megan. On the MCOs, I want to say since I've been here, we've had 3 MCOs, but they go out for bid how often, and are we statutorily bound to 3 MCOs, or could that be reduced or increased, or is that just the number available that can handle the caseloads?
That is a really good question. I don't believe that it's statutory, but I will also say that there are members from the agency, from KDHE here, and they can speak to that. The contracts, I believe they've been 5-year contracts.
Yeah, yeah, oh, yeah, that'd be great if you can kind of help. And feel free, anytime you want, just, you can jump up to the mic. Welcome to.
Christine Osterlund, Deputy Secretary of Agency Integration and the State Medicaid Director. Apologize, wasn't here last week. I was sick. I still don't have much of a voice, but I'm going to do my best. The reason that we have 3 MCOs, Megan was correct, it is not statutory. We do it based on the number of lives that we cover. So if you went with 2 MCOs, there is a federal requirement that you must have choice, so you have to have more than one. The risk if you go with 2 is if one of the plans for some reason would choose to depart the state, whether they felt like they weren't making enough money or for whatever reason, then we would not have choice, and therefore we could not operate a managed care program, and we would have no mechanism to deliver services. The reason we don't do 4 is we only have about 460,000 lives, and if you divide that by 4, you're getting to a very low number for each managed care plan to have where they can be financially viable. You have to have a good mix of membership to be financially viable. So that's why we've always chose 3, but it is not statutorily mandated. Yeah.
Representative Brownlee Page?
Thank you, Mr. Chairman. Can you give us some numbers on how many employees you have for each segment? Would you have that? The number who work for you?
Do you know how many total we have? About 8. Yeah, about 600. Yeah, in healthcare finance, probably about 600. About over 300 of those, 300 and about 13, I think, are tied to eligibility processing. And then the other remainder would be tied to running the Medicaid program, overseeing the MCOs and all the other activities that we do. But we can get the exact number for you.
Thank you. Thank you.
Thank you. All right, moving forward to slide number 3. The top, it says capitation payments. Anytime you hear about caseloads specifically, but Medicaid, you're going to hear about capitation payments. These are the payments that are made to the MCOs from the state. So like I said, there's the 3 MCOs, and KDHE pays the MCOs each month on a per member per month basis. So for each person that's enrolled in Medicaid, for that MCO receives a specific amount for that individual, and that's based on how they're eligible for the program, and I'll go into that a little bit further up. So for example, if there is a child that is enrolled because they meet the poverty level eligibility, then they might be $100 a month. I'm making that up completely, but for purposes of an example, they might be $100 a month because they're probably going to be relatively healthy and their interactions with the medical system are going to be pretty minor. based on the average in the past for that eligibility category. But if you have a child that's in long-term care, they're going to be much more expensive and require much more expensive care. So their per member per month price that's paid to the MCO is going to be much more.
Representative Riley?
So I think that brought up a question is, you have a new person based on actuary numbers on that new person. Who gets to decide out of those three, who gets that person? Do they have a pricing? Do they bid on that new person? How does that happen?
The members self-select, so they can select the MCO that they prefer to work with.
So based on that, sounds like a good system for patients or people to decide where they want to go. So if they all decided to go to Sunflower, then what do you do to control the balance?
So Megan's correct that every member has an option to choose an MCO. Some of them do not. And if they do not choose, then we do what we call an auto assignment process. It has several factors that go into it. So essentially, if you were enrolled in the last 90 days, let's say you lost eligibility for a temporary point of time, you came back on, last time you were in United, we would auto assign you back to United, kind of looking at continuity of care. If you have family members that are in Medicaid eligible and now you become Medicaid eligible, we would put you in the MCO that your other family members are. If none of those factors apply, it's a round robin. It just, this one goes to this plan, this member goes to that plan, this member goes to that plan, keeping families together, of course. And then once either you self-select an MCO or you're auto-assigned, you automatically get a 90-day open enrollment period to, if you change your mind. That happens probably more frequently with someone who is auto-assigned, that they may start working with that plan and kind of think, not sure this is a great fit. And then just like us, once a year, they also get an annual open enrollment period where they can make a choice once a year. But that's kind of how the enrollment process happens.
Representative Hellwood?
Yes, thank you. And this is probably a question for KDHE there. So can you tell us about what you're paying these MCOs throughout the system?
We can get you exact figures, but capitation payments per MCO each month is in the 20 millions. And one thing I would note with that, and Megan may cover this later, but when you look at the cost distribution, and she mentioned this earlier, our nursing home and our HCBS waiver populations are very expensive. Capitation payments can run $7,000, $8,000 per member per month. So while if you look at the enrollment numbers, over 60% of our enrollees are children, they only make up 20% of the cost. 80% of the cost in the Medicaid program is for our disabled, our long-term care members, so it's a disproportionate comparison of cost to enrollment.
Representative Bergkamp?
Thank you, Mr. Chair. Might have to bear with me for a second on this. So we have this 400-some thousand population who require Medicaid insurance, but sometimes providers don't want to provide it. So how do we say, like, you sign up for it, but then who's responsible for making sure that that person can get the coverage that they've signed up for, if that makes sense?
Yeah, no, it does make sense. So obviously the MCOs have a lot of requirements in their contract, and then that's KDHE's responsibility to oversee the MCOs to ensure that care is delivered. So we have pay for performance measures, we have liquidated damages, we have other things that we can do that when we are overseeing them, if we identify there are gaps in the coverage actually being provided, then we have carrots and we have sticks. That we can apply if there is an issue.
And then just as a follow-up, so I think I heard at one point, maybe there's going to be a new website that might detail some, like a scoreboard type thing of here's our expectation versus how they're performing. Is that related to this?
Yeah, so we've been, at KDHE, we've created a data bureau, and I think that was mentioned last week in the presentation, and that was one of the reasons for creating that bureau, is to be able to make more information available to the public, kind of a scorecard, if you will, for lack of a better word, on the MCOs. One thing I will say with that is, with Healthy Blue being new, obviously it will take us several months to start to have like real data around Healthy Blue, where we have access to their live dashboards, but obviously we can't make that public. So it'll be a few months yet, but yes, we will be posting data so others can see how the MCOs are performing.
Thank you.
With regard to the MCO payment question, this table that you have in front of you, for each fiscal year, you can see the amount at the bottom, that total, where it says total Medicaid programs in the yellow line. And that top line is the all funds line. So this is between KDHE and KDADS. This is the number that, not all of it, this doesn't include admin, this does only include medical service, or I'm sorry, other assistance, so those funds that do go out to Medicaid recipients. But that being said, it's not all under CanCare, so it's not all going to the MCOs, but the vast majority of it is. But that gives you a sense of how much is going out. All right, I'll move on to the next slide, provider reimbursements. So whereas the MCOs are paid on a per member per month, the providers are paid via service for the most part. So the state provides the MCOs the monthly amount based on the number of people that are enrolled, and then the MCOs pay the providers based on the services that the providers provide. So for example, if a pediatrician does a routine well check, then the MCO would reimburse them for that service. Or if they provided an x-ray, they would get reimbursed for that service to the Medicaid recipient. So each MCO sets its own rates for providers. So if you're a provider working for one MCO, you might get a slightly different rate from another MCO. That is within their purview. What the state does is the state is in charge of setting a floor amount. So the state sets a minimum amount that they can pay the MCOs, or I'm sorry, the state sets a minimum amount that the providers can be paid for a particular service. So when the legislature makes changes and they make additions to the budget to raise rates, what that's raising is that state floor. So it's telling the MCO providers, you cannot pay any more than this. And then the providers, the MCOs must pay that to the providers who are providing a particular service. Any questions about that?
Representative Riley?
Thank you, Mr. Chair. So at that point, it kind of, what you were doing, explaining, the money that goes to MCOs, similar kind of thing of what we used to have at PPOs kind of thing, where doctors would just get a certain amount of money every month. And based on that, it was their job to try to keep those people healthy. I think that's the underlying thing. So what I've heard from some of my constituents is this other side of the balance of, you have doctors that are trying to keep people healthy, and so they do their best they can to keep them in, the calls in the office and get, your flu shots and all that kind of stuff and keep these people healthy. But then I hear the opposite side of that from these MCOs, or not from them, about these MCOs, that it takes a long time to get the money, and so therefore they're stalling. And so therefore they're having millions of dollars that they have access to, that they make money on. And there are, I'm sure, physicians and hospitals and independent people are very upset at how long takes to get their payments, and sometimes they just keep turning them down for valid thing. You didn't put a period here on your, what you turned in. This number is not right on your coding. And that really irritates people. So is there anything that the state can do about that, or are people to talk about those kind of things?
Well, I would say there are two things that come to mind. The first is that there is the Bethel Committee, and the Bethel is the CanCare Oversight Committee. And at the beginning of almost every Bethel meeting, there's an opportunity for stakeholders to come and present to the committee. And so individuals can come in, or providers can come in and discuss any of the challenges they're facing with the CanCare program and let the committee know so the committee can take action if they should decide to do so. There's also an ombudsman for CanCare that individuals can reach out to. And then finally, within the MCO contracts, there's a pay for performance. So they're provided their full amount when they meet certain performance measures. And those are reported on to the agency and also to Bethel.
Thank you, Mr. Chair. So back up to that, then, are you saying that hospitals, doctors, physicians, independent providers have access to the dates and where those locations are, that they can come and say, we keep getting screwed over by these people, and they have the ability on a website or something to say, Sunflower is doing a lousy job, we need to do something about that. Don't mean to be picking on Sunflower, but I'm just saying the providers have the ability to do that, and maybe that they don't get enough time, or they don't have the right location in order to come and complain, that kind of thing?
All of the legislative work is public knowledge, so it's all public, so they can access it that way. I also understand that KDHE has some pathways for grievances that providers and individuals have. I don't know the details on that, but there are ways that individuals and providers can reach out to the agency and express those concerns so that progress can be made.
Representative Bergkamp?
Thank you, Mr. Chair. Just real quick, is there a place we can find the reimbursement rates? Is there a location, or, because a lot of times we talk about it, but I mean, it'd just be nice sometimes to see what those are across the board.
You can access the minimum reimbursement rates. It's by CPT code, and there are about 33,000 of them. So it's a very long document with many lines. It's not particularly easy to navigate, but they are out there. That is public knowledge, and all providers have access to that. But in terms of what the MCOs are paying the providers, that is not something that we have access to. When we do the caseload estimates, we do our estimates based on the average that each of the MCOs is getting for that particular rate cell.
Thank you.
All right, I'll move on to slide number 8. At the top it says capitation payments. So again, these capitation payments are the state payments that are made to the MCOs. And these are by and large the #1 driver of the Medicaid program. Most of the payments or the funding that the state provides for Medicaid is put into these capitation payments that pay the MCOs to pay the providers. So as I said before, they're based on the number of people that are estimated to need a particular service in a certain rate cell or for the reason that they're eligible. Because Medicaid serves such a wide range of individuals, if everyone got the same rate, it really wouldn't work because, like Ms. Osterlund said, there are more children on Medicaid, but they make up the biggest percentage population-wise, but they're a very small number cost-wise because they're a relatively healthy population that doesn't require intensive needs, whereas we have rate cells for pregnant women or aging and medically needy, and that's a population that's going to require a lot more medical intervention and cost more. So if you look at the next slide, it talks about rate cells. And rate cells is the term that we use to organize how those capitation payments are made. And this is how we approach the caseload estimates. So each rate cell reflects a particular group based on how they're eligible for Medicaid. So whether they're a child that's eligible because they fall under the poverty line, or whether it's an adult that's eligible because they have a disability of some kind, they're going to fall into a particular rate cell based on the reason that they are qualifying for the program. So there are 34 rate cells in the Medicaid program. They range from everything from the various waivers to poverty level eligible children to long-term care, pregnant women, medically needy. And each of those groups has a unique rate. And so when we're looking at the program as a whole, we're looking at each of those rates times the number of people.
Representative Riley?
Which brings it, thank you, Mr. Leader, Mr. Chair. Brings me to the question then, so is that a federal breakdown of those different rate cells, or is that a state-created rate cells, or is that MCO decision of how those are broke down? Who decides those?
I believe it's federally mandated for the most part. There are eligibility that rarely changes within the program, and so it stayed the same through various MCOs, and it's federal.
Representative Burkamp?
Thank you, Mr. Chair. So I assume it's kind of like our insurance where each year you have to re-elect for this coverage. So is the department then ensuring that people who re-elect are still qualified for these, or is it automatic renewal?
No, everyone is, there's continuous eligibility for a year, and then at the end of a year, every single person is reevaluated to ensure that they're still eligible for services.
Thank you.
Yeah, go ahead. Okay. I had a question, but you might cover it coming up here, so.
Okay. So the next slide says caseload estimates. So I wanted to discuss caseload estimates for a moment because it is a part of Medicaid spending. It's not all of Medicaid spending, so I wanted to just talk about that relationship. So the Human Services Caseload Estimating Team, we meet twice a year. It's the agencies involved, so KDADS, KDHE. Caseloads also includes funding for DCF or foster care and TANF cash assistance. And the Division of Budget is also there. And we use data that's provided by the agencies and estimates that they've created. Then we all go in and we all do our individual research and look at policies that have changed in the past, look at the population charts and how the population is increasing or decreasing for each of those rate cells, and try to understand and forecast where they're going to be going in the future. The caseload estimates are strictly for those services that are entitlement services. So there are those services that within the Medicaid program are required to be provided. So the federal government has guidelines on a minimum amount of services and types of services that need to be provided by the state in order to draw down that federal funding. And the Medicaid caseloads include those expenditures. So they're including those expenditures that are federally required. So when you look at Medicaid caseloads, they do not include waiver services. They do include the medical services for those that are the individuals that are on the waiver because they qualify for Medicaid, so they are mandated to receive certain medical services. But the waivers are a state option, so they're not included. Another example of something that's not included is CHIP. So the caseload estimates are a condensed section of the Medicaid program. And it's, the reason behind it really is to budget for this particular set of services that the state is required to provide by federal guidelines. And I did provide, the gray handout is the caseloads memo. Each time we create a new caseloads estimate, we write a memo that outlines the changes that have occurred from the past estimate and why those changes occurred, any policy changes that impacted it, any population fluctuations, things like that. So the memo is just a good way to get a pretty condensed version of why there were changes made to those estimates.
Question, Representative Pickert?
Thank you, Mr. Chair. So just kind of on an average, how often do these changes happen? Is it more than once a year, or I know it has to do with legislation and those kind of things, but quarterly, I mean, you know, kind of what's the average?
Changes to the Medicaid program? It depends on how you're looking at changes. There are small changes, incremental changes that are made to ensure that the program is meeting federal guidelines that are made on a very regular basis. Those are generally smaller changes, such as expanding a service or adding something so that the state is meeting those federal guidelines. And without that, without having made that change, then the federal funding would not be able to be drawn down. Any rate increases or changes that are made outside of federally mandated changes are made by the legislature. And when we do the caseload process, the agency brings us any changes that they've made. We review all of those changes, and we look at them and ask, was this a federally mandated change? Would we lose federal funding if we didn't do it? What is the cost of it? And anything that is significant, we will bring to the legislature, or we always put it in the caseloads memo so that the legislators are aware.
So do you kind of put on your calendar, I mean, we'll probably meet, you know, next month, or, I mean, is it, how, are you meeting every time you turn around, or is it, you know? I know you don't know for sure, but kind of in general, you probably have some kind of an idea, maybe.
Well, for the caseloads estimates, that group that meets, we meet twice a year. We meet in the fall and in the spring, and then we use those numbers to influence the upcoming budget and then the budget that is being passed. And during those times, the agencies will bring to us changes that have occurred or that they foresee needing to occur based on upcoming guidelines in that future fiscal year.
Thank you.
Mm-hmm.
Representative Riley?
And thank you, Mr. Chair. So, and probably other people already know this information, but just a background. So when that caseload information comes through the House and the Senate, what committees in the House and in the Senate get those caseload numbers and affects their budget?
When the memo is written, so that twice a year, we email it out to all legislative leadership, and then the executive, the Division of Budget emails it out to their executive leadership. And then I regularly present it to House Appropriations, Senate Ways and Means. Generally, I'll present it, the information in the caseloads estimates at the joint budget meeting for Senate House, or Senate Ways and Means and HAP, and that's when the governor presents her budget recommendation. So aside from that, sometimes I'll present it to the Bethel Committee. Sometimes I'll do an overview with Social Services budget. It just depends on who asks for it. But the Senate Ways and Means and House Appropriations always receive it. All right. The next slide is MCO rates. The MCO rates actually played a pretty large part in this previous caseload estimate, so the estimate that we're seeing in the budget bill right now. The rates were increased, and that caused an increase in what the state was paying to the MCOs. The one thing about the MCO rates, however, is that while there is variance in what the what the MCOs have as their rates that they pay providers and in what rates they receive, they're heavily regulated by federal guidelines. So speaking to the question earlier about ensuring that individuals can get the services that they need, one of the guidelines is that the Medicaid rates must be high enough that a sufficient number of providers will be willing to join the Medicaid program and accept Medicaid patients. So they must meet, the state has to consistently monitor where the providers are and ensure that the MCOs are meeting those guidelines in terms of where the services are being provided and ensuring that there is that they're able to meet the needs. And then on the other hand, they must be low enough that they prevent unnecessary utilization. So there's a pretty narrow window that the rates can fall into, and each time the agency makes a rate adjustment, they do it with actuaries, and the rates need to be certified as being actuarially sound, and then they're sent to CMS, and CMS has to also accept the rates.
Representative Riley.
Thank you, Mr. Chair. So, just based on what you just said, though, you could have 100 providers in the Kansas City area, and you would have none in Ulysses. So how do you incorporate or get more providers, enough providers for that population out on that side of Kansas in order to cover them? How do you force these MCOs to provide that?
That might be something that Christine can speak to, but I know that there are some regional differences.
Yeah, so both for federal requirement, which is also in our MCO contract, there's called time and distance standards for all the provider types. So there's a whole network adequacy evaluation that's done to ensure time and distance. The only exceptions that can be allowed is if it's actually a desert. And so then we'd have to look at like Kansas licensure board. So like, for instance, neonatologist in Kansas, we have lots of deserts where that provider just doesn't practice in those counties. And so it's not a Medicaid problem, it's a Kansas licensure problem. And so then there's federal guidelines of when you can allow an exception. But to your question about, that's when Megan was referring to the MCOs sometimes have to pay higher rates than the Medicaid rate. Their contractual requirement to us is to meet provider network adequacy standards. And that means if I reimburse you out of the fee schedule $100 for that code, but the MCO, the only way they can get a network is if they reimburse the provider at $120 for that code. That's what the MCO has to do to get that provider in network to meet adequacy standards.
So, thank you, Mr. Chair. So what you're saying is, and there are doctors out of Wichita that drive, fly, whatever, out to western Kansas in order to provide services once a week to different places around. So those doctors, and sometimes they're ARPNs that go with them, they are reimbursed at a higher rate because of that, quote, desert?
They could be. I mean, we don't, from a KDHE perspective, I don't know what the MCO pays each individual provider. I can only ensure and see that they're paying them at least the Medicaid rate. What I can tell you from the rate study that we're doing, I can now see the codes, which the MCOs on average are paying well above our fee schedule. the rate study's given us a lot of insight into where that's happening. We've dug a little bit deeper into like which providers. So you are seeing things like that where you might have a provider in Dodge City that might be the only provider of that type, and they're garnering a pretty nice rate from the MCOs. Other times it might be a very large practice in Kansas City that has a lot of bargaining power that might be getting higher rates. So it's going to be kind of all of the above. But what we hold the MCOs to is we quarterly review their network adequacy, and essentially they have to meet that, and we have to submit that to CMS, and CMS has to validate that they meet it. So it isn't like KDHE on our own could say, well, you know, I'm going to give them a pass on this. It doesn't work that way. It's our review, just like on the actuarial rates, it's our review, and then it's CMS's review to ensure compliance. But we are able to see a little bit now of what's happening where the MCOs are having to pay higher rates to attract providers to the network.
Representative Brownlee-Page.
Do you offer telemedicine as well?
Yes. So we do telemedicine. We're looking at, I think one of the things that the public health emergency did is it kind of, I would say, accelerated the use of telemedicine, even in the Medicaid program, and we were given some flexibilities from the federal government around telemedicine, which are going to continue long-term. And we are now exploring, looking at what some other states' experience are, where there's companies now that are forming that don't practice in a particular state. They're solely a company that just does telemedicine in a variety of specialties. We're learning from some other states' experience around some of the challenges maybe. Some of those companies are very good, as you can imagine. Some of them, there's some credentialing issues. There's maybe some providers that there's a reason they're doing telemedicine. So we're trying to learn from those lessons, but we want to bring those best practices to Kansas, so there'll be more work continue to be done around telehealth. But over the last 5 years, it's expanded pretty rapidly in Kansas Medicaid program, but we're hoping to expand it more, and especially in the areas where we have, you know, deserts, of being able to bring access to care to more of our Kansans.
Thank you.
Representative Burkamp.
Thank you, Mr. Chair. On the topic of deserts, are neurologists considered a desert in Kansas? Because I know, like Sedgwick County, I don't think we have any that accept Medicaid.
Yeah, there are some deserts for a lot of our specialty types in Kansas. Typically, what you'll have in some of these specialties is kind of to the comment earlier, where you'll have providers that are in a larger location that will do clinic hours, or they'll do a day a week or a day a month. They'll go out to some of these smaller communities and provide those services, and so there's coverage, if you will. But yeah, we do have a lot of the specialty providers. You see it with OBGYNs. That's becoming a larger problem just holistically in Kansas, of more and more counties where we don't have OBGYNs. So it's something we monitor really closely, because while again, not all a Medicaid problem, it definitely really impacts our program.
And then is the rule, if a doctor takes one Medicaid patient, they have to take any Medicaid patient, or how does that work on that front?
They will contract that with the MCO, and that's called their panel. And so some providers will have a larger Medicaid panel than other providers. You might have some providers that will say, I'll take a small number. I might take, if I'm a specialist, I might take 10. And you might have another provider, and I know one actually testified in front of the House that like 40% of her patient load is Medicaid. So it's going to be all over the board. But that's part of that panel size, is part of what makes up network adequacy, that you're ensuring that while you may have a lot of names, is the panel size adequate?
Yeah, because I guess I was just talking to somebody back home, and I guess their understanding was if they maybe open that door, then they couldn't restrict the amount of patients that they had to receive. So I think that was maybe some of the hesitation on that front. And I don't know if it's maybe an education issue on their front or what, but maybe a possibility to expand access on certain things.
That is a good, and you're right. There could be some providers that don't understand that they have a little bit of say, if you will, in how many Medicaid patients they may want to take. So that's a really good point, and that's feedback that we can take to the provider team, that might be some good outreach to do to make sure providers are aware of that.
Thank you.
All right, moving on to slide 9. This talks about other cost drivers. So while capitation payments make up the largest cost driver in Medicaid, there's also the federal medical assistance percentage, the FMAP. And this is what we discussed in the previous committee, that is the federal match rate for the state's payments for Medicaid. So it's determined every year. It changes every year. So each year we're working with a different FMAP percent. And so each year for the entire cost of the Medicaid program, the amount that the state has to pay shifts slightly. So for example, in fiscal year 25, the FMAP or the federal share was 65.75%, and in fiscal year 26, it was 64.69%. I don't know what impact this had on the program as a whole, but I know for caseloads, that shift from the 65.7 to 64.6 was about $30 million difference. So it does cause quite a significant shift when you're dealing with such large amounts of money. I'm sorry?
Representative Pickert?
I'm sorry, but was that money from the feds that came to Kansas? Is that what you're saying? $30 million difference?
That
Less, yeah.
30 million is what the state had to pay in addition, because the federal government was paying slightly less.
Thank you.
On the 30 million, is that an apples to apples comparison, or were there additional caseloads that influenced the 30 million?
That was, we isolated the impact of the FMAP shift, and it was 30 million.
So that is
That
a
was-
strict comparison.
Yes.
Well, Representative Riley?
Thank you, Mr. Chair. And so from the federal government's point of view, which budget does that come out of? Is that, which agency does that money come out of? Who controls that percentage?
I believe it's set by the Health and Human Services. All right, on the next slide, it talks about other cost drivers. So other cost drivers that we see that influence the Medicaid program are federal policy changes. So some examples of that are the Disproportionate Share Hospital, or DSH program. This is funding that goes out to hospitals to help compensate for uncompensated care expenditures that they accrue. And that amount has been legislated to go down at the federal level. There's also a health insurance provider fee that the state was paying on behalf of the MCOs for several years, and that has been repealed. That made a difference in the caseload amounts, or I'm sorry, in the Medicaid amounts. On a state level, provider assessments, right now in the budget bill and House Bill 2007, there is language to raise the hospital provider assessment from 3% to 6%. That will not make a difference for the SGF portion of the Medicaid program, but it will draw down a significantly higher amount of federal funds coming into the state that will then be reimbursed back out into the hospitals. And then also rate increases impact the amount that the Medicaid program is costing.
Megan, can you go back to the provider assessments? Can you walk through that percentage change and how does that all work?
So it's the Healthcare Access Improvement Program, and it is a program that the hospitals are required to pay 3% on their net income for inpatient and outpatient services. And then they pay that on top of what they have to pay for the Medicaid program. And then the state adds that to what they pay the MCOs. And then because we get that 60% match, then we get a higher match back for that additional money, and then that additional funding is sent back out to the hospitals. It's difficult to understand, and I'm pretty sure I didn't do it justice, but I do have a memo on it that is much more clear that I could provide. But it is, in short, it's taking advantage of the higher federal match, and it's bringing down more federal dollars than would have been brought down otherwise, because the hospitals are paying a little bit more. And then that money that they paid into it, plus that additional federal funding, goes back out to the hospitals. So it's a benefit to the hospitals.
Representative Brownlee Page.
How are you affected by the current administration in regard to the feds part? Are you expecting any cuts on that level? There's a lot going on. So how are you affected by the feds currently, today?
At this point, I don't know of anything that has officially occurred. I know that I have read many articles about various effects that could come into play. I don't know if the agency has more information on that.
Yeah, there's no impact yet, but obviously we are closely monitoring, what's happening at the, federal level, and at the point that, if anything passes, then we would assess what the impact would be for Kansas. But so far, nothing has, been made official.
Representative Humphreys.
Okay, thank you, Mr. Chair. If I could just real quickly go back to the FMAP question that I had. So if, so our percentage is less in 2026, and it's based on the per capita personal income. So that means our per capita personal income went up if we're getting a lower percentage, right?
So it's based on a 3-year average.
Okay,
So
yeah.
it's not going to be, there's not going to be a direct correlation.
But that would be true. If the FMAP's going down, that 3-year average went up.
Correct.
Okay, and do you see that 3-year, or, the average of per capita income goes up, do you see a resulting less need, less number of caseloads?
That's a good question. I don't know that we've ever looked into that correlation, but nothing that is obvious.
Yeah, because why, they pay less because why? I mean, if our per capita income went up, why would the FMAP be less?
My understanding is that it's based on that, if the state has a higher per capita income, then it's likely in a healthier spot to pay a higher rate.
Yeah, that's what I was just curious, but okay. Okay, thank you. Thank you, Mr. Chair.
Representative Carr.
Thank you, Mr. Chair, and thank you for your so detailed presentation. My question is this, with respect to the drawdown from the federal government. If in fact Kansas was to do something like expand Medicaid, then would that not increase the amount of drawdown that we would get from the federal government if we increase those services with an expansion to Medicaid?
Yes, it would increase it in 2 ways. One is that the Medicaid expansion population, so that segment of Medicaid would receive a 90% match rate, federal match rate. And then the other piece is that right now, the federal government has a policy where states that newly expand can draw down an additional 5% for the regular Medicaid population. So the population of Medicaid that receives that FMAP, excluding the expansion population.
Thank you.
Representative Simmons.
Thank you, Mr. Chair. That 90% match rate, what is it right now without expanding?
That,
That is the,
it's a population that's right now not eligible for Medicaid. So there is no match rate for that population. They're not on Medicaid.
so in theory, it would go, never mind. I'm tracking with what you're saying. Thank you.
All right, the last two charts I have, or the last two slides, are two charts. The first is this historical expenditures look for the major Medicaid programs. So this is what is on the legal size paper that you have. This is condensed into a chart, so it's a little bit easier to digest. And you can see that in the last couple of years, there has been a pretty significant increase. The lighter color at the top of the bar charts is the SGF. And then if you combine that with the bottom color, that's the all funds amount.
Megan, often all funds includes SGF.
Correct. It includes federal funding, any special revenue funds that are used to offset state general fund and state general funds.
So if, I'm trying to understand your chart, this one, kind of the bar graph, if you have all funds, let's say for instance, 2026, all funds would be 6.6 million, 6.7 million. If we look at the state general fund, that's included in the 6.7 million. So looking at the bar graph, it doesn't actually, we're not actually into the over 8.
Correct.
$8
You're right.
billion.
I see. That was an error on my part. I did the chart incorrectly. It should be, let me call your attention to this. So if you follow the column that says fiscal year 26 all the way down to the bottom, so that top line in the yellow row is 6.7, and that is the total amount that is being spent on Medicaid, federal, state general fund, special revenue fund. And then the line below that, that 2.0 million, is state general fund. So yes, I will fix that. Thank you for noticing that.
Representative Simmons?
Thank you, Mr. Chair. This is so interesting. I'm looking at this line under Department for Aging and Disability Services on autism, and I'm noticing there's quite a bit of difference in the numbers across the years. Could you please, if you know, perhaps provide some context to why there's such variation?
That is, I have an idea, but I'm going to get more details and I'll send it to you, just so I don't misspeak.
On that, could you send that to
The committee.
Gary as well for the whole committee? Thank you. Representative Bergkamp?
Thank you, Mr. Chair. Do you know how our spending, like, per enrollee compares to Missouri, Oklahoma? Like, are our benefits in line with theirs, or is there quite a bit of difference in what we offer versus the states around us?
I don't, and there are so many factors that would come into play, whether they've expanded Medicaid, which most of the states surrounding us have, or what services they provide. It's difficult to make a direct comparison.
Would like the CHIPS be a little bit more comparable, since maybe that, because expanded Medicaid wouldn't really affect that population, right? I mean, we have several subsets that wouldn't affect. Is that fair?
I think one way to look at it, and I believe that KDHE is working on this now, is to look at the rates that providers are paid, because that really does influence a significant piece of the Medicaid expenditures. So that would be one place to start that would give a good sense between state to state what they're spending.
Thank you.
Representative Helwig?
I got a question we really haven't touched on today, came up the other day, is Medicaid unwinding. So I guess my understanding of Medicaid unwinding, they're reevaluating eligibility, whether people be off Medicaid, and we've seen a significant drop in number of people on Medicaid. but yet expenditures seem to be going up substantially. Can you explain that to me?
I can. So if you look at the historical membership chart, you can see there that there is a dip starting in 2023, moving into 2024, and that was the Medicaid unwinding. The unwinding process is largely over. So that was the process of removing all of those individuals that had been on Medicaid during the public health emergency, because at that point, the agency was not able to remove anyone from Medicaid. The process to go and reevaluate every individual is finished. And so we're now back at where we would expect to be at a pretty stable rate. The reason that you don't see, that you really see the inverse with expenditures going up is there are two reasons. The first being that, by and large, those populations that have the most turnover in Medicaid are those that are eligible for poverty, that fall below the poverty eligibility level. And by and large, that's a pretty inexpensive population. They're not on because they have a disability. And so even though we lost a significant number of people, we didn't see a huge drop. We didn't see the drop in expenditures that you would have seen had you stopped serving a waiver population or something like that. But then the other half of that is this paper right here. And if you look at, starts at 2019 legislature, so those were the changes that occurred in fiscal year 2020. And you can see that at first there aren't really significant numbers of changes, but then you get into, on page 3, the fiscal year 24 legislature. And there were some really significant additions made by the legislature that impacted the program's expenditures. And that's really why you see that number going up.
I can follow up with one more. So a lot of those people came off during the unwinding. Are they now eligible for the .gov? I've heard there's a little gap there between Medicaid and being eligible for .gov. Can you speak to any of that?
I believe that there is a gap. I know that as part of the unwinding process, KDHE worked with each individual to help them find a program that would work for them, whether it was the healthcare.gov or something else. Some of the children that were no longer eligible for Medicaid would have been eligible for CHIP. So I know that they worked to make sure that if there was a program available for those individuals, they would find it.
Thank you.
Representative Riley.
Thank you, Mr. Chair. So I don't know what page number this was, but it was the one that you had, the rate sales one. Mm-hmm. And so, you know, you were saying right now that there's 34 rate cells. So if there was an expansion of Medicaid, would there have to be another rate cell for individuals that are over 18, under 55, that would fit there? They would have to add another rate cell for them. They would have their own specific pricing and everything. Is that correct?
Yes, and that would be necessary because they would have a different federal match rate. So when the agency was budgeting, that they would need to know for that population specifically how much they would, the state share would be.
On the capitation rates, so how often are they recalculated for the MCOs?
Twice a year, I believe it's twice a year.
And then what are they intended to cover? Is it like a full, or I'll just stop there. What's the capitation?
The per member per month price that's paid to the MCOs, what is that intended to cover? Is that your question? That's intended to cover the expenditures for that individual based on how they qualify.
Is that just a full, that's intended to cover that individual for the entire 6 months until a new capitation rate could be adjusted? So is that, is it like a no deductible for the state premium payment? That's all we have to really worry about for that individual then, is that capitation payment? And then the MCO is taking the risk or the reward from there?
Yes, so they're paid per member, right? And then if that member that month doesn't go to the doctor at all, then that's a win for the MCO financially. But if that member falls and breaks their leg and requires surgery, then the capitation rates are designed so that they even out that.
So then if they're looked at twice a year, and they probably are going to go up because all the costs are continually going up, that's going to essentially turn around and be an increased cost to the state.
Yes, as the MCO rates are increased, that's
all part of the contract with the MCOs, to where that's just it's going to be a cost to the state. That's a variable that pretty much the legislature doesn't have control over, other than that's the policy that we pass, correct?
The contract is one that the rates are evaluated every twice a year. And the reason for that is that, like Christine said, the agency has to consistently make sure that the MCOs are meeting the requirements for being able to serve the number of people, as well as making sure that the MCO reimbursements are meeting the expenses that they're incurring. So, does that answer your question?
The other thing that I would add is the actuarial process to set rates is very defined by the federal government. It's actually based on, for actuaries, there's actually a guidebook that talks about setting actuarial sound rates. So like, for instance, one of the items, to your point about rates always going up, actuarially sound rates have to include medical inflation. They have to include acuity. And so it's a very, very prescribed process for actuarially sound rates that we're required to follow as a state to certify and sign off by our actuary that that's what we're submitting to CMS and for them to approve. So typically, yes, because you don't see in healthcare, you don't see, when new services come on the market, for example, like we have drugs coming on the market now that we're required to cover as Medicaid that are millions of dollars per member. Yeah. And those are mandated coverages. And so there's just a lot that goes into this that is outside of the state's control. The federal government owns the majority of this program, and we're required to follow that. The consequence of not following it, we could choose not to. Every state has that right. Federal government has the right to say we're going to withhold our federal match. And so, the reality is we have to do what they say, and then just with healthcare, new services come on the market, new coverages, new drugs. You have healthcare inflation, kind of the way of the world, but all of that is accounted for when we set rates. We do what we can. I know you guys hear a lot of complaints around prior authorization. I understand it from the provider's perspective, believe me. It's a way to try to get at controlling costs. There's very few levers we have to control cost in Medicaid, and they come with trade-offs. If you set prior authorization too strict, you create a lot of provider abrasion. You don't have them strict enough, you have overutilization. So it's always that really delicate balance of what's that middle ground that we're doing right by our providers, which we really want to do, but we're doing right by the taxpayers and trying to keep utilization into a place where you have some predictability in the cost of the Medicaid program.
So we'll go Representative Bergkamp, Pickens, and Simmons. So Representative Bergkamp.
Oh, thank you, Mr. Chair. And kind of on that note on healthcare costs, are there metrics that the federal government or state government utilizes to say how are people getting healthier on this program to reduce cost, or are there any metrics that say our population's getting healthier as opposed to getting worse and we're just spending more? Like if we're going the wrong direction, we're never going to decrease our costs.
So unfortunately, from the federal level, and Megan alluded to this, a lot of what we do is under the umbrella of an entitlement, period. And so even if our population is getting sicker, I cannot stop providing those services to those members if I want to receive federal match. But with that being said, at the federal level, we do look at that at the state level. We've tried in this CanCare 3.0 contract to put in some liquidated damages around trying to see better health outcomes in certain populations. We put in some requirements around care coordination, trying to get at making the population healthier. But I also will say, the MCOs, because 80% of the cost are 20% of the members, a lot of them being our HCBS members, the more stable they keep them, keeping them in their home, keeping them out of the ER, that helps them make money, but it's also a cost savings to the state. So we try to set it up where it's a win-win, that the way that the MCOs, and if you look at the Bethel slides, you'll see their profit margins. Their profit margins are minimal. I mean, they're not making money off of Medicaid, but the way they can influence that is by helping the acuity of our patients. So we try to set it up as a win-win, that if they're doing their job right, it will help them save some money, but it will also save our members. They'll have better health outcomes, and then ultimately that saves the taxpayers as well.
Thank you.
Representative Pickard.
Thank you, Mr. Chair. Do the MCOs have any ability to negotiate medications or anything like that?
So we set the preferred drug list, so, and we do get drug rebates. So they, for the most part, they have to follow what we mandate as the state. There are some flexibilities when you're talking going off of the preferred drug list around prior authorizations and different levers that they have, but it's kind of minimal in the pharmacy area.
Representative Simmons.
Thank you, Mr. Chair. Previous representative mentioned something about gaps. Do you know if Medicaid expansion would cover any of those individuals that are falling into that gap?
Well, Medicaid expansion would add folks to coverage, and you know, we do hear from like our FQHCs and our providers that serve the uninsured that some of those would now be covered by Medicaid, which means yes, those providers would get a reimbursement for those members instead of it being uncompensated care. We don't have statistics on it, obviously, because they're not, you know, part of the Medicaid population today, but we do hear that routinely from, and especially certain providers, certain provider types that typically, you know, serve those populations.
We've talked a little bit about different deserts. Would that assist with that at all in any way? Do you think it might encourage more folks?
You know, I won't just sit here and say it's a one-for-one, but I do think it, you know, it would. I mean, obviously, the more people that you, as a provider, the more people that are in coverage, then if you're looking at going to a community, the more people that have insurance, you're kind of guaranteed payment, if you will, versus if you're in an area where there's a high uninsured population. So yes, you know, it definitely could.
Thank you, Mr. Chair.
Representative Helwig.
I know it's a lot of information. Oh, thank you, Mr. Chair. Could you provide us, and I don't expect you to do it off the top of your head, but there's different groups and different people. You got 7 or 8 different groups there. Could you provide what the income level or the gap or what triggers a person to be qualified for Medicaid currently?
So, yeah, I can give you a high-level fact sheet. One of the things I will point out is we'll give you kind of the basics on federal poverty level. I will tell you that eligibility is not easy, and especially when you get into long-term care and the waiver populations, there's a lot of income disregards, and there's a lot of other factors that come into play. But yes, we can generally give you, like for instance, a parent or a caretaker, you have to be at 39% of the federal poverty level to qualify for Medicaid. If you're not disabled, you're not pregnant, you're not HCBS, or you're not in a nursing home, but you're just a parent or a caretaker, it's 39%. of the federal poverty level to qualify.
Well, thank you very much. And got one more slide and probably a few more questions, Megan. Is that right?
Yeah, I believe that's on my slides. The membership chart was the last one, which illustrates that unwinding period. But I'm happy to stand for questions over any of the presentation materials or the handouts.
Representative Helwig?
Thank you, Mr. Chair. I do have one more question. As I look at this historical membership, as we go through here, 2015 to 2020, it's almost flat. It actually goes down just a little. Then I understand 2020, we all know what happened there. Through 2023, it rises significantly. So, and then you said earlier that we went through the unwinding, we pretty much pulled everybody off that doesn't qualify. But that sure seems like it's out of balance from what the trend was going into 2020 as to where we're at in 2024. Did the eligibility change? What's going on there that that flat line didn't continue?
Eligibility did not change. It's really, I think, just an increase in population. I don't know if you have more to add.
Yeah, there really wasn't a lot eligibility change. There was for pregnant women, the coverage was extended to 12 months versus 3 months. There was some movement, some small movement in reducing the wait list for the waiver, so we added more individuals on the waiver, but again, small numbers. But a lot of it is just kind of the nature of, you know, people's employment and, you know, and their status for Medicaid.
And if you could, we just talked about on the previous questions, if you could provide us with the list of the requirements for all the different waivers and autism and just everything, if you could provide that, I'd sure appreciate it.
Okay.
Thank you.
And I don't know if you want to answer this or Megan, but on the changes, the legislative changes, can you just walk through the IDD change that the legislature did in 2024 and kind of talk through briefly just what the waiver is, how that mechanism works, and then what the legislature changed and kind of the effects from that.
So waiver services are programs that are put in place to provide services in the community for individuals that, because of whatever they're experiencing, would likely otherwise be in an institution. So it's community-based services. And the IDD waiver is specifically for those who have intellectual and developmentally disabilities. It provides a variety of services. They're like job support, attendant care, any service that an individual with those special needs would require that other populations might not.
Can you talk about the waiver? So what's the mechanism? What is a waiver? How does that work? And then,
In general, a waiver is a change that the state can make to the federally mandated program to provide services in a different way. And it has to be, I believe it has to be neutral in cost, right? You have to.
Cost effective.
Cost effective so that it's not causing the federal government to pay more. That the services that the waiver provides is saving money based on what that population might otherwise need, such as an institution.
it's interesting, you have the eligibility, and then we have the IDD. It would seem that they would be eligible. Why is there a wait list? Why isn't that just part of the Medicaid system? Why does there need to be a waiver?
So waiver are not considered mandatory services under the federal government. And so any person that becomes eligible for Medicaid, you are eligible for what we call state plan services. So those are services that we've agreed with the federal government. Most of those are mandated by the federal government that will supply to anybody who's eligible. Where waivers come in is what a waiver really means is we're asking CMS to waive the rules. The typical rule of Medicaid is it's the same for everybody. So we are saying we have a very special population, IDD, for example. So we want to design a program just for this population. But people not on the waiver are not going to get these services. So what happens when someone comes onto the IDD waiver, they get all the services on the IDD waiver, plus they get all the state plan services. Everybody else on Medicaid, if you're on just traditional Medicaid, all you get is the state plan services. You are not going to get any of the IDD waiver services because we don't cover those for everybody. So we're basically creating a select population. So each of the waivers have a different array of services based on, whether they're serving the autism folks, or brain injured folks, or IDD folks. Each waiver has a set of services that is specific to that waiver, and the only way I get those services is I've been approved to be in that waiver.
Representative Humphries?
Thank you. Thank you for explaining that, because I've always thought waiver, and I've asked for years this question. I've always thought waiver was such a strange word to use, and it's confusing until you understand what it is. So you just did a great job explaining it.
Well, good.
So because, from the ground view, it's like you're on the IDD list, or you're on the autism list, the OK list, we could call it. But really, you have to call it a waiver because you're looking at it sort of from where you are up to the federal government. Yeah. But down where we are, it's, the list. So I appreciate the way you explained it. That was super helpful.
Yeah, terminology. And then the other thing a waiver allows you, because again, we're creating this select population, is that you can then limit enrollment in that population, unlike our mandatory eligibility groups like our children, and all of those groups that are mandatory. That's entitlement. That means anybody who's eligible automatically gets on, again, in a waiver, because you're creating this subset. You can limit enrollment, which is why we end up with wait lists, because there you do have more control. You can say, we're going to have so many slots. And then once those slots are filled, you get a wait list. You can't do that for regular Medicaid. It's if you're eligible, you're eligible.
Representative Pickard?
Thank you, Mr. Chair. So see if I'm misstating anything, but so the wait list for the IDD is long, but with my experience with the IDD community, parents are encouraged when their child turns about 10 to get them on the wait list. They're not ready for services yet because they're in school and they're getting a lot of those special services through their special education and that kind of thing. But when they hit 20, those services are cut off from the school system, and then they need to go on the IDD waiver if their number is high enough. I mean, if they have hit the top of the wait list. So that it's kind of inflated right now, the wait list, because we have a lot of younger kids that aren't old enough. Is that correct?
I'd really have to get with ks because they manage the waiver and they know a lot more of those details than I do. But yes, I am aware that yes, people, are applying, if you will, when they're younger, knowing that there's a wait list and it can take several years to get on. But I can reach out to them and have them follow up.
Thank you.
Representative Riley?
So talking about waivers, one of the things that we brought up at our last committee meeting, which our state has, that the federal government doesn't have, one of those things is that we cover dental care. And so that was literally a waiver because we were doing something different than what the government mandated. Is that not correct?
So, oh yes, all the Medicaid nuances, right? So dental services for adults is not a mandatory service under the Medicaid program. It is considered an optional service. But if I choose to pick it up as an optional service, unlike an optional eligibility group like the waivers, I actually do that through the state plan, because what it means is that any adult, regardless of which program they're in, any adult that's eligible gets those services. So I don't have to do a waiver, I have to do a state plan amendment. So this is the lovely nuances of Medicaid. Yes, but.
Okay, thank you very much. It's a little bit after 3, so we'll probably wrap it up. But yeah, thank you, Megan. Thank you, Director, for coming in today and being available in the presentation. Yeah, I think we're going to try to continue with these a little bit for the rest of this year and certainly into next year. It's a big program. It does kind of fit into the welfare committee because it is a entitlement welfare program, and certainly want to understand it a little bit better so that when we make decisions, hopefully they are even better decisions than what normally comes out of the committee. So with that, today is Tuesday. We have 2 hearings on Thursday. And then I'll just kind of prep you a little bit. One of the hearings, the bills on the cross-check bill. And there's, over the last couple of years, been a lot of back and forth, different perspectives on the cross-check concept. And the hope is that the hearing will be able to flush out a little bit more understanding. And then I might even do an informational hearing next week on the cross-check processes. Because when we have people saying completely different things with regards to the same topic, they both can't be correct. So there might be some misunderstanding. So we're going to try to get to the bottom of it. And then based on the outcomes there, we'll decide whether we're going to work the bill or not. So it's kind of a little bit of a look ahead to the next couple of weeks. With that, thank you, committee. Thank you, staff. We are adjourned.